Okay. Okay. Right. So impact slide, and today's it's got a very strong impact on you, I can tell. It's somewhere in Greek island, and you know what's happening over here. It started off well with all these kind of romantic scenario, and I don't know how many of you are waiting for that. I've already been through that. And then it comes out to be this scenario. And you'll be amazed that this kind of scenario came like in a couple of days. So that's very unhappy ending, I would say. But I'm going to give you another assignment today. And those of you who remember, and this actually is from one of the newspapers, and the story goes like this, that the tuberculosis patient, the man in that romantic picture, he basically was here on May 10th, 2 days before leaving Atlanta for his wedding in Greece. That's what he was there for. And he sees a county health department officer who tells him not to travel. Not to travel. And then he basically, after that warning, he basically has at least 7 commercial flights. So he takes 7 commercial flights, and one of them is, of course, transatlantic. And the transatlantic is about 8 hours, and then he goes to Greece. And as he has his bride, he marries over there, and then to cut the story short, just like Typhoid Mary, CD is going to chase him up, and CDC wants to bring him back. So he just has a good time for, I would say, like 2 weeks. He comes back, and then he lands in Atlanta, and then he makes big news. He makes big news, and the question for you is, I'm going to give you 2 pictures. I'm going to ask you this question. You may have to dig out, not today, some other time, to find out what is going on, because that's what I'm going to discuss today. So this is the first picture shot, a faithful bride. You know, she stays with her husband, GMA exclusive news. And then in a couple of hours a day, the GMA then publishes this picture. So do you see the difference? What's the difference? The mask goes from her to him. So that's the question for you. Why would that happen? And I'm going to take you to the rest of the slides today. Okay. One of our P1 students, so that was a beauty contest. I don't know. But I want you to pay attention to piercing. She has like 1, 2, 3, 4, 5. 5 piercing. And then we have another gentleman. He wasn't a P1 student though. But he has more piercings. You see, quite a few piercings. Okay? Now, I'm going to give you an analogy to figure out what is going on in this case. So she stands as a gram-positive cell wall. So she's a gram-positive cell wall, and you already know the answer. The other gentleman happens to be a mycobacterial cell wall. Okay, so you see a lot of piercing, lot of studying, you know, that kind of stuff. Keep in your mind, this is mycolic acid. That's the take of this slide, mycolic acid, right? And I'm going to take you to some of the cell wall structure that we already had discussed earlier. In this picture, mycobacterial cell wall, again, you have a gram-positive bacteria, cytoplasmic membrane, and being gram-positive, it has a peptidoglycan layer, and then this has a complicated structure that you saw the complication in that gentleman. And one of the most important thing, as I said, is mycolic acid, which is C60 to C90 carbon. Then it has 2 more important structure, arabinogalactan and lipoarabinomannan. And we're talking about mycobacterium. And also remember the staining that we talked about, comparison between gram-positive, gram-negative, and mycobacteria. And mycobacteria remains a challenge because The more complicated your cell wall is, the more challenges we have. So you can see from here, again, a typical gram-positive bacteria with a small peptidoglycan layer, and then two more layers added, arabinogalactan, lipoarabinomannan, studded with mycolic acid, and then you have trehalose dimethyl on the exterior. And the thing that I want you to understand in this structure is that mycobacterial cell wall is rich in waxes and lipids. So waxes and lipids, especially mycolic acid, right? And the other important thing is that you can see it does have a peptidoglycan layer. It will not stain with the gram staining. But the most important components in mycobacterial cell wall is arabinogalactan, and you can see it has a structure and it has a place immediately on top of peptidoglycan, whereas lipoarabinomannan is like a hair-like projection, goes all the way from cytoplasmic membrane to exterior. And since it's going to be podcasted and posted, uploaded as well, so I would want you to pay attention to the legend of the figure that I just showed you, the cell envelope of mycobacterial cell wall. So I'm going to spend a little bit of time to give you an idea, because if you do understand the structure of mycobacterial cell wall, it will be easy for you to understand tuberculosis as a disease, and then anti-TB therapy, and then it's one of the most complicated therapy that we have. Okay, so bear with me with some of the pictures. I'm going to show it to you just for a concept, and you can see from here. Well, I just took it out from, again, this is a beauty contest. I mean, you'll be amazed to know there's a beauty contest in Europe where we want to beautify people, especially young girls, to lose the weight, to such an extent that according to the contester, this happens to be most beautiful. That's what it is. So if you compare with the structure over here, this young girl has in terms of her muscle mass, in terms of her bony skeleton. So in this case, just compare her with another structure where the muscles are developed. Now, both of them have the same set of muscles, correct? So there's a development of muscle. There are some of the things are exaggerated. And then again, I'm not going to go in detail and tell you whether she was on steroids or not, but I can just tell you that, of course, she must have stopped eating, or she may have some psychological illness, so on and so forth, right? But both of them basically are in a context. One, of course, a bodybuilding context, others a beautifying context where you lose weight and they think more thinner you are, more beautiful you are, or more attractive you are. But the message is that both of them are gram-positive. Okay? So this is kind of an analogy you have to keep in mind when we compare for any gram-positive versus any mycobacterial. So you can see over here, basically very, very thick muscle mass, compare that with thick peptidoglycan layer. And the more important thing is, again, a very complex set of muscles and so on and so forth. Now, if you take that as a gram-positive, again, lipid-rich cell wall, 60% are transport proteins and porins, and that constitutes 15% of the cell wall weight. So that's the lipid portion of that particular mycobacteria that I gave you an analogy for the female body building. Okay? And the next slide is a little bit kind of awful. So, well, again, it is a piercing context where people want to compete. How far can you go in terms of getting your body pierced? But what I want to tell you in this case is that basically mycobacteria causes tissue damage. So there is a tissue damage. And this kind of so-called odd behavior I would kind of link it to human beings. So the point over here is for mycobacteria, humans are the only natural reservoir. So you can only expect humans to do this kind of stuff. Anyway, so let's go to the disease itself, Mycobacterium tuberculosis. Again, still a challenge, and I'm going to go through in detail today. And you can see from here, mycobacterium are inhaled. It goes over here in the respiratory tract. It finds a primary tissue disease over here. And this pretty tissue disease is a immunological response where body wants to wall off. So that's another concept, if you remember, immune system, when body wants to wall off an area. So if this happens to be a area where bacteria is, then the body wants to bring in all those cells around this, T cells and macrophages, and make a structure that appears like a granuloma. We call it granuloma. So there's like a structure, a granuloma. The whole idea is that it wants to contain, this body responds to contain a obnoxious agent. So that's what is happening over here. And then again, this lesion will cavitate. So you'll have a firm caseous core over here, like sometimes you have a boil, and in the boil, in the deeper part of the boil, you see that pus-forming caseous material. So caseous material, cheesy-like material, is a typical of TB. Now, I expect you to look at the immunology, chronic immunology responses, especially hypersensitive type 4. I'm going to leave quite a few slides for you to recap or catch up with that. And it's all based upon the information that we have already covered. But if you understand the point, it's more like a chronic inflammation. And to cut the story short, so you can see from here, when infection takes place, again, we have the cells respond over here, which in this case happen to be IL-12, TLR2, and then again, dendritic cells also play a role, and there's a presentation of the antigen of TB or mycobacteria to different sets of cells. So you can see MSC class 2, and then again CD4 T cells are recruited. If it's MSC class 1, then again CD8 cells will be recruited. In this case, you can see. And then the whole idea for immune response is to contain. And also remember, this is an intracellular organism. So this means it can hide in your cells and sit over there. So that property of any microorganism to go and hide in your system is called latency. So this means you've been infected. It stays in the system, is waiting for the right time to come out. It's just like your immune system goes down and you're stressed out, and that gives this bacteria a chance to go and find out a way to cause a problem. Okay? So mycobacteria, as we discussed earlier, would not stain with gram stainings. You have to have a special staining because it will not be decolorized with acid solution, and you know, because of the complexity of the cell wall. That is why we call it acid-fast bacteria. Okay? And again, I'm going to spend a couple of slides on the structure of it. And this is something that you need to remember. And I can just tell you upfront that I'm going to give you a question, and I will label all these A, B, C, D, and I want you to know in order of outside in or inside out, whichever way you want to look at it. So the question will say, which one of this or is the innermost layer? Or look at the sequence of layer in terms of their configuration. So in this case, if you pay attention, A is a plasma membrane. That is I would say, the innermost, right? Typical plasma membrane. Then E basically are plasma-associated and cell-associated proteins. So these are like those proteins over here, okay? And these P are the phosphate molecules. So you can see tons of phosphate molecules over here. And then again, if you pay attention, like for example, D basically is a mannose cap lipoarabinomannan. So that basically, the whole structure over here is lipoarabinomannan that you saw like a stringy rope-like structure in the previous picture. And then again, you will see over here, phosphate is there, is a peptidoglycan layer, and then you have a structure C, which is arabinogalactan, as compared to lipoarabinomannan. So these are the two differences. I can't remember of any mnemonic right now, but I can just tell you that arabinogalactan is more of a structured thing, as a layered thing, as compared to lipoarabinomannan, which basically has a lipo portion. So just imagine the lipo portion is like something wavy portion which is hanging out of the structure of the cell wall. Then we have this mycolic acid that I gave you with this piercing thing, if you can remember that. And then again, glycolipid surface molecules are there. They are associated with those mycolic acid. And these glycolipids basically, if you understand, are like sticking molecules, some of the antigens which are out there. And also remember, since most of the structural elements are proteins, so proteins will mount a very severe response, body immune response. In a picture, we'll give you the same message. Cell membrane, peptidoglycan, and lipoarabinomannan. You can see lipo portion, I just said, hanging out, waving his hand outside, lipo, and then arabinogalactan is over here. So this again is a structural element of a typical mycobacterial cell wall. If you were to stain them by acid-fast staining in a sputum sample, this is what you get. So you can see very darkly stained, red colored, and people will cough them out. And again, if you remember me saying earlier, how many bacteria do you need to have a TB? I said 1, right? So you can imagine if this one, the person is coughing on your face, sneezing on your face, sitting next to you, and he has a TB, very serious problem. Okay, then you will wonder, okay, I'm not going to sit next to a person who has TB. Well, you're going to be in hospital, you're going to see HIV patients, and you are a physician or pharmacist, so what are you going to do? And very rarely you will see, especially physicians in the clinician, wearing masks. But again, you have to be very careful and be watchful of the infection that nosocomial are prone to you when you work in health-related field. Okay, so this was Mycobacterium in sputum, and you can see basically cells are there in the background, and this basically is a staining with methylene blue. We have carbylfuchsin, that's another stain that normally stains bacteria, carbylfuchsin, and then methylene blue will stain this epithelial cells in this sample. And again, this is a typical counter stain that we have, and you can read the legend if you want to. Okay. So physiology and structure-wise, let's do the family as a whole. The genus, the Mycobacterium genus, is non-motile, non-spore forming, important. Aerobic, and again, if it's aerobic, it's going to love to go to your lungs because it wants to breathe, and that's where the maximum oxygen will be. As far as size is concerned, 0.2, 0.6 to 10 micrometer. And also remember the slide when I told you gram negative rods of respiratory system, and it's depending upon the size, where would they lodge in. Rich in lipids, that will make the surface hydrophobic, simple. And then they are resistant to many disinfectant and common lab stains. That was a challenge that we have. And then again, since the wall is complex, it's very difficult to grow in a lab. And if they do grow, they divide very slowly, 12 to 24 hours. And as a matter of fact, that just reminds me that when I started my master's in England, the very first task they gave me to work on Mycobacterium, and my task was to culture them and grow them. But the problem I had was that I wanted to finish my master's within a year, and it took 24 hours to grow. And I had to wait like 1 month for them to be visible under the microscope. So I did some research and found out, as part of my research as well, I developed a method to do that, and I call that Fazal's method. And it's published, so that's one of my achievements that I always try to kind of highlight in my CV. Anyway, so bacterial. Okay, this is an extra credit for clapping. Okay, who clapped? Okay, so acid fastness, that's the most important thing that we have. Presence of mycolic acid, and guess what? Since I'm emphasizing mycolic acid, over and over again, I showed you that nasty piercing as well. So be prepared that there is a mycolic acid chain in nocardia as well, right? So some other species of bacteria can be acid fast. Nocardia, they stain less intensively, are partially acid fast, and their mycolic acid chains are shorter. So that is the difference between nocardia and Mycobacterium, because both of them have mycolic acid, but the chains are shorter. So that's important. Then again, 61 to 71% of guanine plus cytosine, that's a GC context and DNA. So there's a DNA difference as well in terms of guanine plus cytosine in mycobacteria as compared to any other acid fast. Because I just said that mycobacterium is acid fast, doesn't mean this is the only one. So nocardia is also acid fast because they contain mycolic acid. Okay, so what benefit does mycobacteria get if it has such a complex and lipid-rich cell wall? Now, number one, the characteristic that is going to come from that structure is acid fastness. They grow very slowly. They are resistant to detergents. They are resistant to common antibacterial antibiotics. So if you give any so-called antibiotics, they would not work. And those of you who know anti-TB therapy, we have like 3 to 4 drugs, combination of drugs, anywhere from 3 months to 9 months. So there's a very long therapy and there's a patient compliance issue and so forth. So we called it directly observed therapy because patient would not take the medicine and they have side effects of medicine and they have all this kind of weird nausea, vomiting, diarrhea, and so forth. So you want to make sure that patient take anti-TB therapy in front of you. But for 3 months, 6 months, 9 months, that's tough. We call that as directly observed therapy, DOT. Anyway, antigenicity because of the natures, and then clumping. Clumping is something that you saw, they tend to clump together. So that's again something sticks them together. Okay. Now, again, I would let you read all this stuff, but this basically is coming from all those 3 pictorial slides that I gave it to you. So those of you who have a visual memory, I would suggest that they want to go through those 2-3 pictures that I've posted over there, and pretty much the same information is there. The different layers of mycobacterial cell wall, the way they're arranged from outside in, and the structure of mycolic acid, and cell weight, and so on and so forth. But again, lipoarabinomannan, as I said, lipid is that wavy rope-like structure, as were to arabinogalactan. So these are the 2 important molecules that are out there. And some of our anti-TB therapy is going to target that. Now, this thing that you must have heard, you all got PPD test. Those of you who were born here, and those of you who were born outside US, they basically should not be getting a PPD or Monto test. They should have their X-rays done. And we already discussed that. I don't want to go in detail. It's a type 4 hypersensitivity reaction. And then again, the classical example at that time was the purified protein derivatives, which are coming from Mycobacterium. But of course, we don't take it from Mycobacterium tuberculosis. We would rather take it from some other less virulent or benign Mycobacterium, like Mycobacterium bovis, that causes TB in animals. Okay, now Mycobacterium tuberculosis, and it so occurs, I don't know, today is 25th, right? Is it 25th today? Well, last year I taught this on 24th, so that's a coincidence. That happens to be the World TB Day. So yesterday was World TB Day, and they always celebrate that because they want to commemorate 1882 when this German physician Robert Koch, he discovered Mycobacterium tuberculosis. So that kind of remains as one of the leading causes of death. Unfortunately, 2 billion people are infected with MTB over the world. There cannot be any other disease than that. So what's the population of the world? 7 billion? So like you can say 1 in 7, 1 in 5, or 1 in 4. So you can see very high, but this keeps on changing. And then also remember, infection does not mean disease. So right now, if we are 50 of us, we may be infected. And actually, the chances are, for those of us who come from other part of the world, that our bodies have already seen BCG or Mycobacterium, and we may have it. But at least our immune system knows that with BCG vaccination. And those of you who haven't seen BCG vaccination, you can ask your friends if they want you to look at the ugly scars that it makes on their upper arm. So People die with it. So it's a serious problem all over the world. And well, in this part of the world, we were not that kind of watchful. But since HIV patients are getting TB, so now we've become really concerned. Foreign-born person, that again is important, and I'm going to show you the data that CDC wants to maintain. I don't know, because I know for sure that it's an immigration requirement for you to produce your TB status. They're not going to give you a green card or whatever. I don't know about the visit, though. I doubt if that's the case. But again, people can come over here, and you saw that guy over, that. And, I mean, I didn't tell you the whole story. The person who flew from Atlanta, having multi-drug resistant TB, right? He basically was son-in-law of the person in CDC Atlanta who was running the lab for TB. So he was so brave a person, he got his daughter married to a person who had multi-drug resistant TB. And it's very severe kind of a disease. You understand the point? So the whole thing is that CDC does want to maintain a record and find out how the statistics go. I don't know how can they control it, but I'm going to give you quite a few data for multi-drug resistant TB and what the problems are. And people look normal. People look normal. And they have this disease in them, and sometimes it shows, and sometimes it doesn't show. So anyway, if you look at the disease pattern, as I already showed you in the previous picture, for example, people will cough out. The person will cough out, right? And other person will inhale. So it's there. If, for example, if a person who has a TB happens to be in this area, and he comes, and you are not here, and then you come and sit over there or walk through the aisle or whatever, so you will pick that up, right? It goes into your lung, and then lymph nodes basically want to take it up as an antigen sampling. It's going to stay in your system and will be circulating via lymphatic drainage. And then again, it can also be absorbed through blood and go wherever the blood takes it, okay? Now this is called, like the first one over here is called primary tuberculosis. So primary tuberculosis is always in lungs. There is no organ in the body that is immune from getting TB. So almost all body parts, even brain, you get TB meningitis, TB uterus, TB fallopian, you name it, TB skin, so on and so forth. Now, what happens is in alveolar macrophages, that's what it is, and then again, it's going to sit over there, hide for good, because one of the things it will do is, if you remember, it's going to elicit a delayed type hypersensitivity, DTH. So you'll have all the sequel events of DTH, your cells will come, and then you'll have that kind of a skin rash, skin response, they're going to measure it. And then again, two things can happen. One thing is that your body can control that, your immune system is good enough, and fight that off, or you get disease. Okay? But as I said earlier, you may have this particular bacteria sitting in one of your alveolar macrophages, and alveolar macrophages can live long, right? And then they will wait for the time that the immune system goes down. And if your immunity goes down, they will reactivate. We call reactivation. That happens especially in the upper lobes. So if you were to look at the TB lungs, you would see that their upper lobes have got cavitation. We call cavitation. So these are like granulomas over here. And there's a tissue injury there, and very severe form of tissue injury. Now, as I said earlier, I'm not going to spend much time, but I want you to read on your own. It's pretty much the same information that I've been talking about over and over again. That is an intracellular pathogen. So intracellular pathogens basically go over there, and they have a mechanism to survive. One of the mechanisms they have is they would, because once you take in a microorganism, it forms phagosome. And in your cell, you have lysosome. So phagosome, lysosome should fuse. So lysosome discharges the killing material into phagosome to kill them. But mycobacteria basically would block that. So that blocking basically is by a bridging molecule we call endosomal autoantigen, endosomal autoantigen 1. So that's what is happening over here. And then this bacteria will survive. And then the typical story for the chronic bacterial is that you got initially acute inflammation, you got IL-12 secretion, TNF-alpha secretion, And then again, you have T cells coming over here, activation of cell, pretty much chronic inflammation that you normally see. That's why at that time when I was working on TB, we had a very big group in England and then in Germany. And at that time, they were thinking that TNF alpha is the one that basically, it's called tumor necrosis factor, that TB people get cachexia. Cachexia is like, you saw that woman, so she's normal, the skinny, but that happened in cancer patient. You lose your muscle mass. Clinically, we call cachexia. So they thought it was coming from TNF alpha. And we wanted to block TNF alpha. So Wellcome at that time in England, head office, they were spending a lot of money, and they still are, coming up with TB therapy. And my other colleagues in my other labs, they were working on developing the test for TB because there were no tests available. I was growing them up in my tissue culture plates and so on and so forth. And at that time, we were trying anti-TNF drugs, thalidomide and many others. And I did mention thalidomide, which was like antidepressant. And those women who took it in pregnancy, so they had deformed babies. So we had a lot of concerns at that time that how much of TNF we need to block. But TNF remains as one of the major players over here. Gamma interferon, again, if you remember, it sensitizes macrophages. It causes appearance of MSC class 2. And it kind of kicks in for the mycobacteria, for the macrophages to do something to actually kill the inherent or the contained mycobacteria in them. Okay. So immune response, as I said earlier, typically the same. One thing that I did not mention in immunology, other than what we already showed in these couple of slides, and I would want you to read them on your own and see the pictures from the immunology book of type 4 hypersensitivity reaction. But one thing that I did not discover at that time was, for example, there is no known mycobacterial toxin or enzyme. So the destruction that you get, the tissue destruction is coming from your out of control immune response. Your own immune response is acting. That's where and of course for a good reason, because you have been infected by mycobacteria. Okay. The other thing I did not mention, again, I'm going to spend some time, is granuloma. So granuloma, if you want to read it up, basically is a response by human body to contain, to ward off, to seal off, to contain bacteria. And what happens is that you have a central bacteria and all the cells will come and surround it. So you have different lymphocytes, all these Langerhans cells and fibrosis and so on and so forth, because you want to contain the bacteria. So if you look at that bacteria, if you look at the structure of the lungs, you'll see little nodules everywhere, nodules. So they look like nodules, but if you look under the microscope, they are a granuloma of a primary structure. And many a time the questions usually asked are, what is it in the central caseous necrosis? So in central caseous necrosis, you will see bacteria over here. And then again, the outermost layer is fibroblast. The whole idea is the body wants to contain it. If you want to look at the structure, this is how they grow. They kind of clump together. We also call it cording, C-O-R-D-I-N-G. And then there are some other stains that we want to stain them with. Remember, I just told you that I myself had a challenge because I don't want to wait like 1 month to have my data to collect on TB, because they take a long time to grow. So we have to come up with many things. One of the things that I developed was radioactivity. So we want to put a radioisotope like tritium into this bacteria and run them on the radioactive machine. So it's going to show if they are moving up. Clinically, you can see from here, tuberculous cervical lymphadenitis is called scrofula as well, and it has a sinus formation. So you see that kind of granuloma, and it's a caseous material inside. Sometimes it leaks out to the skin and forms a sinus, a tunnel. So you see oozing out of that caseous cheesy material. That's what it is. Okay? And then again, as I said, every part of your body can be involved. Sinus formation, skin is informed. Very difficult to heal, especially over here, because you have to do something. You cannot use local antibiotics, and antibiotics, again, gram-positives are not going to work. As far as epidemiology is concerned, again, as I just said, is present worldwide. There are always new cases. It's very common in Southeast Asia, Sub-Saharan Africa. You will hear that a lot, Sub-Saharan Africa. Eastern Europe for some reason. And this Ukraine, Romania, and all these countries are there. And then again, we do have a lower incidence, but I'm going to talk about today. The population at risk, especially in this country, are HIV patient, drug or alcohol abuser, homeless person, blah, blah. So there's a good reason, because they think that if your nutritional status is not good, if you're depressed, right, and some socio-economical factor will add on to you, like too many people overcrowding and things of that nature, and they are spread by person to person. If a mother has it, baby will have it. So that's, again, important problem. And the data which I'm going to show you to you, I just downloaded this morning. So you can see from here, reported TB cases, 1982 to 2011. And you can see there was a resurgence 1985 to 1992. And now, hopefully, it's going down. So there are many different causes for that, especially AIDS epidemic came in that part. So I can tell you that. If you look at the across the different states, so you can see that we have higher rate cases, more than 3.4 per 100,000. So Alaska, all these, I would say most of them are warmer, but again, the question will come, I'm going to talk about that, is also immigration, indigenous population, and people, foreign-born people sitting and moving in this area. So if you compare, for example, 2001 and 2011, this is like percentage of TB cases, and this is the foreign-born. So you can see, as people are moving in from all those high-risk areas, and again, it's updated June 24, 2012, you will see that it's kind of moving towards the center. So within 10 years, pretty much have taken over the whole US continent. So if you look at the countries of birth of those people who are born, so they call it like imported cases of TB. So they want to go back and look at where those people are coming from, and this is what the data suggests. So Mexicans have like 22%, Philippines 11%, Vietnam 8%, India 8%, China, Guatemala, Haiti, and then tons of other countries. So these are the common countries where people kind of immigrate and they bring in the TB to this part of the world. Okay, then again, if you want to compare statistically against the races, and you can see Asians have the highest percentage of TB, and then again, we have Native Hawaiian for some reason, and then we have Hispanic. The Black or African or American have low, unless and until they have, I mean, this is over here, lower than other them, but the lowest one is basically in white population as compared to TB, unless, of course, if they have HIV. So these, and there was a surge, you can see over here, 2006 and 2007, especially in Hispanic or Latino population. So CDC does maintain that data, but you can argue what's the point of maintaining if you let that person go and get married in Greece? So co-infection, that was another thing that I wanted you to pay attention. The reason for co-infection, I'm going to ask you, because you need cell-mediated immunity to fight TB, and if you lose your CD4 T cells in HIV, you will have a problem. Age, 25 to 24 is an age factor as well, and you can see over time, though it's declining, but we had a very high incidence in early 90s when the AIDS epidemic was really ripe, and we have tons of youngsters involved in HIV and AIDS. Again, primary TB, multi-drug resistant TB, US born versus foreign born. Again, you will see US born have a lower as compared to foreign born people. And I'm not going to go in the world statistics. I would want you to read on your own, but you can see India and Far East, Eastern Europe, part of Russia and China, Sub-Sahara Desert, Alaska, and many other countries have a higher incidence, and again goes by quite a few statistical analysis that you saw. If you look at European countries, again, what you want to see is that the former Soviet Union, for some reason, Eastern Bloc, has a very high incidence for TB, and the same bloc has a higher incidence for HIV as well, and other STDs as well. And we'll discuss that when we talk up STD. Okay, this is from your book, and then you can see from here a number of cases. But as I said, the figures that I downloaded this morning, they're going to be posted on Moodle. So I would rather want you to look at those because they are more updated than the book that we have. A mycobacterial colony growing. And of course, you cannot see it like this. You have to be in a very high protective area, and because it's going to be in air. So we do not have that facility over here. There are like very highly protected environmental things that we have to take care because the bacteria will go in the air. How do you diagnose? Simple diagnosis is that you can do a Montos test and then do your work backwards from there. You can look at microscopy and culture, especially if person is oozing out blood, molecular probes, and then again, didn't put my name because I should have, if you would Google it, Fazal's method of counting colony, but that again is not a commercially made kit, otherwise I wouldn't be standing over here and talking to you. I would rather be in the Greece or somewhere else. Okay. TB, so you can see a typical area over here, condensation, and mostly on the epiphysis because it wants to grow in oxygen-rich area. So if you look at the lungs, the oxygen concentration is higher on the lobes. That's where the bacteria goes and sits over there. The other thing that you normally see is hilar adenopathy. So the lymph nodes are in the central mediastinum. So they get infected, and then you have the problem, and they can go and biopsy that through the bronchoscope. How do you treat them? They're going to spend a lot of time on teaching you, but for my class, of course, I want you to know that it is a multi-drug regimen, and there is a prolonged treatment. And then the problem in the impact slide I just showed you, multi-drug resistant TB. So that again is important. These are some of the drugs that I want you to remember. I'm not going to go in detail. Isoniazid, ethambutol, pyrazinamide, rifampicin. And there was a time we used to use streptomycin, but again, we don't give it any longer because of the side effects. 4 to 6 months, that's a long period, 4 to 6 months because of the, the taste, aftertaste, the discoloration of urine, nausea, all these kind of weird side effects of these drugs. So you can also give a tuberculosis. If you're working in an area, you want to give yourself prophylaxis. So you can either take INH, which is isoniazid, or rifampicin for 4 months, if you happen to in that part of the world doing something, or some other things you can do. Immunoprophylaxis, as I said, most of us born out of the country, they have this BCG vaccination. In US, as a policy, they don't give BCG vaccination because they think that if you give BCG vaccination, the utility of the Montos test will be gone. Because what's the point of doing a Montos test? And then again, they also think that the active disease versus a negative person will also disappear. So sensitivity and specificity of Montos test will be no point doing it. Okay, because they want to keep Montos test. If it becomes positive in an American-born person, this shows that he is or she is suffering from TB. So that's very specific. Then again, CDC does a lot of things over here, and one of the things I just said, want to maintain data, give suggestions, surveillance, and therapeutic intervention, so on and so forth. Again, this was the slide I just picked up this morning to find out what are the drugs as of today are available for FDA approved. So that's another important thing. There's a body over there, FDA, that takes care of that. And again, you will see isoniazid, rifampicin, pyrazinamide, ethambutol, rifapentine, streptomycin, cycloserine, capryomycin, para-aminosalicylic acid, and ethiomide. So these are the 10 drugs. So at least the name part I would want you to remember because all the details will be done away in your following years. But these are important, and I just said that streptomycin is also considered, especially if you have a multi-drug resistant TB. Okay, so you can see from here, I didn't specifically go and teach you the disease per se, but I think you will get an idea that mycobacterial cell wall is complex, and as I said earlier, clinical picture is there's no part of the body that does not have a TB. So you name the body part and there will be TB for that. But again, it starts with the lung. That's where the primary focus is, primary tuberculosis is. And then again, we talked about the latency, we talked about intracellular survivor, we talked about DARTs, directly observed therapy, because people would not take medicine for such a long time. Also keep in mind that drugs are also expensive. So many times people want to take those drugs, but too expensive. And then again, patient compliance, and many of things are there that we wanted to take into account, especially for TB. So we will continue with Mycobacterium, and I will take on the other 2 or 3 Mycobacterium tomorrow.